Thanks for having me. I'm an economist at RAND, and this is some joint work with Dana and Anne and others. It's a kind of an exploratory analysis looking at trying to answer the question or get some traction on the question why patients are not attaining recommended A1C levels and the role of patients setting glycemic targets. As we discussed as Anne discussed in her talk, so tight glycemic control reduces the risk of diabetes complications, so both microvascular and macrovascular complications. And studies like the Diabetes Control and Complications trial, showed this pretty strongly. But despite the fact that tight control reduces complications, many patients with type 1 diabetes are not achieving these recommended levels of control. So to give one example, the T1D Exchange is a large clinical registry that includes adult and pediatric type 1 patients around the country, and over 25,000 patients. And so Roy Beck and his authors, looking at the data from the clinical registry, found that only 18% of patients had A1Cs below the sort of ADA recommended 7%. And so that includes both pediatric and adult patients. And so the level's a little bit higher for when you just look at adult patients, which is what we're looking at in this paper. But it's still, definitely a minority of patients. And so the question we're asking in this question is sort of what are the key factors in this paper? What are the key factors that are leading to these relatively low levels of glycemic control? So Odegard and Capoccia had a paper that reviewed the literature on medication non-adherence in both type 1 and type 2 diabetes. In general, the literature is really focused mostly on type 2 diabetes and adherence and juvenile and pediatric and adolescent patients with type 1 diabetes. But adherence is still an issue for patients for adult patients with type 1 diabetes. And I think this is a useful schematic of different factors leading to non-adherence that they identified in this systematic review. So they first look at patient factors for non-adherence. And so things that they're thinking about here are fears, so fear of hypoglycemia. Another factor is knowledge and skill. So, adhering diabetes treatment regimens, both the medication regimens, but also the sort of lifestyle regimens, may be very complex. So education may be an important factor leading to adherence. So medication is also a factor. So the complexity of medication regimens maybe lead to a better or worse adherence. Cost may be a factor. So testing and insulin supplies may be expensive. And then finally, there may be sort of provider or system-oriented factors that lead to non-adherence, or poor control. So, for example, providers may not provide sufficient support in terms of education or enough education on sort of how to use supplies. So, given the complexity of diabetes treatment regimens, it makes sense that there could be that we may see that there are these educational gradients in adherence and diabetes control. And so Dana and Jim Smith, an economist at RAND, looked at baseline data from the Diabetes Control and Complications trial to look at whether there were these educational differences in treatment adherence. And they found a significant gradient. So patients who had higher levels of education were more likely to monitor more often. They were less likely to miss their insulin injections. And they were more likely to adhere to medication regimens and lifestyle regimens. And so this may reflect that patients with higher levels of education are able to sort of, comprehend and follow these regimens, or it could be a selection effect. So it could be the effective education, or it could be that sort of higher skilled people are selecting into education. So SES may be an important factor in adherence, but another factor could be hypoglycemia. So as Anne was mentioning, when you achieve higher levels of control, it also is associated with higher rates of hypoglycemia. So this was found in the DCCT. So patients who were in the intensive treatment group were more likely to have severe hypoglycemic episodes. And so in this paper by Leiter and others from 2005, they looked at patients who had reported severe hypoglycemias, and they looked at changes in self-management after these episodes. So patients who had a severe hypoglycemic event were more likely to test more often after the event, but they also were more likely to modify their insulin doses to avoid subsequent events. So these results suggest that hypoglycemia may have an important effect on how patients are sort of setting their HbA1c targets and if they're attaining these targets. So this paper is looking at the role of patient glycemic targets. So we're sort of building on this literature that looks at SES gradients, socioeconomic gradients in treatment adherence and glycemic control, and this work looking at the role of hypoglycemia by looking at first sort of patient-level characteristics that are associated with setting an HbA1c target. And then we're going to look at, conditional on having a target, what are the patient-level factors that are associated with setting a more aggressive target. So we're going to look at things like education, other demographic characteristics, as well as the prior hypoglycemic events and role of hypoglycemia. And then we're also going to look at how fear of hypoglycemia affects setting glycemic targets. Then finally, we're going to look at how socioeconomic status and hypoglycemia is associated with the attainment of glycemic targets. So to look at how targets and how the sort of patient targets and how this is related to clinical outcomes, it really requires both patient survey responses and also clinical data. So what we did is we collaborated with the T1D Exchange Clinical Registry, which is a large data collection effort that includes pediatric and adult patients around the country from, I think, something like 65 clinics. So we focused on 24 clinics that had a large number of adult patients, and we sent emails to patients that had respondents and participants in the registry who had expressed interest in participating in studies. And so we sent them an email describing the study, and we performed an online informed consent. And then patients who consented completed a web-based survey that collected information on socioeconomic characteristics, glycemic targets, quality of life, hypoglycemia, and other patient-reported outcomes. So we thought a pretty good response rate given that it was an internet-based survey. So we had 36% of the respondents consent and complete the survey. And then we took the responses from the web survey and linked them with the clinical registry data. So this is a list of the clinics that participated in the study. And as you can see, it's a really diverse set of clinics, both geographically and in terms of the types of clinics. So it includes both centers for research, but also more kind of community clinics. The key variables that we were looking at, so the first was, do respondents report having a glycemic target? So we asked them, do you have a glycemic target? And so this is the first outcome we're going to look at. Next, we looked at, conditional on having a glycemic target, how aggressive is their target? So we specifically broke targets into 3 categories. So we called under 6.5% aggressive. We used a middle category of 6.5 to 7%. And then we also included a less aggressive category of above 7%. Next, we included a question that asked whether a respondent targets their A1C above their physician's target, specifically because they're afraid of hypoglycemia. And then, finally, we compared the most recent HbA1c test from the registry with the patient self-reported target to look at attainment of targets. So we linked these outcomes with a variety of descriptive and variables. These included demographic characteristics such as marital status, age, gender. We included information on education. So if patients had less than a BA, a bachelor's degree, or a graduate degree. We looked at blood glucose monitoring behavior, so the number of tests per day, and then also if they were using CGM, or continuous glucose monitoring. And we also included information on health insurance status and also health status. So I think most importantly, whether patients had prior depression or anxiety problems. So this is an example of sort of what our survey looked like. So this is the question that elicits if patients have a target. And if they answered yes to this question, then the next question was prompted that asked them what was their goal for their A1C. So for our analytic approach, we start with just a sort of descriptive bivariate analysis that just looks at just the distribution of having targets and the aggressiveness of targets across the key explanatory variables. And then we also look at correlates of setting a less aggressive target than your physician because of fear of hypoglycemia. And then we also look at correlates of attaining glycemic targets. So just for a minute, I want to talk about our sample a bit. We had a high fraction of our respondents were female and white. So this is a bit more, our sample was a bit more homogeneous than the sort of overall registry. So in the overall registry, about 80% of the sample is white. Our respondents were highly educated, so 27% had a graduate degree, but we still did have a sort of less educated portion that had a high school degree or less. Our sample was primarily covered by private insurance. Our average A1C was 7.6%, and this is a little bit, indicates a little bit higher control than the overall registry population, which was closer to 8. So the sample reported considerable hypoglycemia. So on average, respondents reported 7 episodes, minor episodes in the past month, and almost a third had a major episode in the past year, which we defined as you had such a bad hypoglycemia that you needed help from someone else. 43% of our sample reported that they set HbA1c targets above their physician due to fear of hypoglycemia, sort of indicating that this is a major issue facing respondents. So I'm going to first just show some differences in whether respondents had a target by their characteristics. So first, you can see that males had sort of a 5 percentage point less likely chance of setting a target than females. Married respondents had about a 5 percentage point, were 5 percentage points more likely to report setting a target. And then I should also add, I mean, one overall finding here is that almost everyone does set a target. So, overall, it's something like over 90%. But you still see these educational gradients. So patients that had less than a bachelor's degree were significantly less likely to set a target than patients with a bachelor's degree or a graduate degree. Patients with private insurance were more likely to set a target than patients with Medicare or the other coverage category that included things like military coverage. So next, I'm going to show some results looking at sort of how aggressive a respondent's target was by different personal characteristics. So this figure is showing the fraction of patients setting sort of less aggressive targets, the middle targets, or more aggressive targets by their educational attainment. And so what you see is that patients setting, patients with less than a bachelor's degree are more likely to be setting a less aggressive target, over 7%, and they're less likely to be setting a more aggressive target. And you find the opposite with patients with a graduate degree. So patients with a graduate degree are more likely to be setting an aggressive target and less likely to be setting a more aggressive target. We find a similar relationship. So for marital status. So married patients are also more likely to be setting an aggressive target and less likely to be setting a more aggressive target, sort of indicating the potential role of social support in targeting behavior. This figure shows how aggressive patients' targets are and how that varies by whether they've had a severe hypoglycemic event in the past 12 months. So patients who, the left side of the graph shows that patients who had a severe low in the past 12 months were less likely to set an aggressive target, whereas patients with a severe low, with no severe low in the past 12 months are more likely to set an aggressive target. And then at the other side of the spectrum, patients with a severe low were more likely to set a less aggressive target. So next we look at more explicitly whether patients who had a severe low were likely to target above their physician because they were worried about hypoglycemia. And so what this figure shows is that the first group, patients who had no severe low in the past 12 months, were less likely to report setting a target above their physician's target than patients who had a severe low in the past 12 months. And so now we're going to look more specifically at, we take this variable, we divide patients into those who set targets above their physician versus patients who don't set targets above their physician, and we look at their self-reported target. And again, this is, as you'd expect, patients who sort of express this fear of hypoglycemia are less likely to set aggressive targets than patients who don't express this fear of hypoglycemia. So I think one thing to take away from all of this, so I think in summary, we find these education gradients in targets, and also it varies by marital status and whether people have had severe hypo events. So this figure shows, based on patients' targets, so aggressive versus less aggressive, their actual most recent A1C. And so what we see here is that patients with more aggressive targets have lower A1Cs than patients with less aggressive targets. And I think here this could be showing both, this is all cross-sectional data, and this could be showing either cause or effect. So it could be that patients that have higher targets, are subsequently have higher A1C levels, but it could be the other way around as well. So it could be that there are other factors that lead patients to have lower levels of control, sort of similar to what Anne was describing, and subsequently they have higher targets. Similarly, we find higher targets among patients who target above their physician, or higher A1C among patients who target above their physician. So finally, I'm going to show some results from some logit regressions so basically, this is kind of horse racing different patient characteristics and looking at correlates of targeting above their physician because of fear of hypoglycemia. So I think some notable significant correlation. So the blue dot indicates the odds ratio, and the tails represent the 95% confidence interval. So some notable significant correlations are patients with a graduate degree are less likely to target above their physician due to fear of hypoglycemia. Married patients are less likely to target above their physician. Patients who had either a sort of above median number of mild hypoglycemic events or a severe hypoglycemia in the past year were more likely to target above their physician, perhaps not surprisingly. And then also patients who had diagnosed depression or anxiety in the past were also likely to target above their physician due to fear of hypoglycemia. So then finally, we're going to look at sort of correlates of patients attaining their own targets. So we compare their most recent lab value to their self-reported target. And we find that patients with higher levels of education, either a bachelor's degree or a graduate degree, are more likely to attain their target. Males and married patients were more likely to achieve their targets. But I think most notably here, patients that express this fear of hypoglycemia were significantly less likely to achieve their self-reported target. So in summary, we found that socioeconomic status is both measured by education or marital status, is associated with both the probability of setting a associated with the probability of setting an HbA1c target, But also, conditional on having a target, it's correlated with setting a more aggressive target. Also, conditional on having a target, patients that had prior hypoglycemic episodes set less aggressive targets. And then once we horse race all these patient characteristics, we found that patients with lower socioeconomic status, more hypoglycemic episodes, and who had prior mental health problems were more likely to set a target that was above their physicians because of fear of going low. Patients with higher SES and who were afraid of hypoglycemia were more likely to attain their HbA1c target, and also patients that monitored their blood glucose more frequently or who used continuous glucose monitoring were more likely to attain their A1c target. So I think all these estimates are correlations, but they suggest the importance of hypoglycemia and fear of hypoglycemia in setting less aggressive targets and attaining the targets that are set. So I think more work is needed to sort of look at how interventions that identify hypoglycemia earlier or work with patients to deal with hypoglycemia may lead to more aggressive targets and improved attainment of targets. So just some acknowledgments. So we acknowledge the T1D Exchange for collaborating with us and working with us to field the surveys, and funding for this was provided by the Institute for Health Technology Studies. Thanks.